When I asked the infection preventionist at the hospital that Josh was at, how did he get this infection? He looked on and said, I just don't know. And that broke me, but it also opened my eyes. No one person can fight every germ, but the system can, if we choose to.
This is the Sepsis Spectrum, a podcast about antimicrobial resistance, sepsis, and how to expect the unexpected in your practice. Not every boy who dreams of the skies gets to visit them. But by 27, Josh Nahum was a skydiving instructor, chasing clouds and saving up to become a child psychologist. On Labor Day weekend 2006, a sudden shift in air density caused Josh's parachute to collapse mid-jump. He hit the ground at 60 miles per hour, breaking his femur and fracturing his skull. Tragic, but thankfully survivable. After nearly 6 weeks in the ICU, Josh was improving and transferred to a local rehab facility. Fast forward 6 days, and he developed nausea and 103-degree fever. Tests revealed Enterobacter aerogens, a hospital-acquired gram-negative bacteria, in Josh's cerebrospinal fluid. That night, Josh coded. An emergency brain procedure saved his life, but resulted in spinal damage that left him a ventilator-dependent quadriplegic. On October 22nd, Josh died, not from his injuries, but from sepsis. Today, we speak with his father, Armando Nahum, and hear about one family's necessary mission born from an unnecessary loss. Hi, everyone, and welcome to the Sepsis Spectrum, or as we like to call this season, Microbial Mysteries. I'm Nicole, critical care nurse and clinical nurse specialist, and your guide through the complicated and sometimes frustrating world of sepsis and antimicrobial resistance. On today's episode, we're going to understand how quality improvement, or QI, plays a key role in catching sepsis, healthcare-associated infections, and antimicrobial resistance early and keeping patients safer. First up is Armando Nahum. You may recognize his name from the story I shared at the beginning of this episode. Armando is a nationally recognized patient safety advocate whose mission began after losing his son to a hospital-acquired infection. He co-founded the SafeCare campaign and has advised major institutions like the CDC and CMS on infection prevention and patient partnership, infection prevention, and system-wide change, including his appointment to the Presidential Advisory Council for Combating Antibiotic-Resistant Bacteria. After the break, Dr. Hudson Garrett will join us. He is one of the most credentialed voices in healthcare safety, quality, and infection prevention. As president and CEO of the Hudson Garrett Group, and with advisory roles to the FDA, CDC, and AORN, he's helped lead the charge in reducing harm and fighting antimicrobial resistance. Together, they offer both clinical insight and lived urgency, an essential pairing in the fight to make patient care safer. Let's welcome to the pod, Armando Nahum. I am privileged to be joined now by Armando Nahum, who you heard the story of his son, Joshua, and his unfortunate, untimely death back in 2006. So now we're gonna talk about what Armando Nahum has done since his son's death. So welcome to the show, Armando.
Hello, and thank you for having me here today. Appreciate it.
Yeah. Oh, thanks so much for joining us. Can you just give us a quick recap of what happened back in 2006?
Sure, be glad to. What I'm about to share is not really just my story. It's a story that touches so many families across the country. And it's a story about infections, not the kind we expect and recover from, but the ones we never see coming. Those that happen in the places that we turn in for healing, the hospitals. So within just 10 months' time, 3 generations of my family, my father, my wife, and my son, each suffers serious, even deadly bacterial infections. Different hospitals, different procedures, different states, but all preventable. And if I may, I'd like to take you back to where all this began. So first was my dad, Quint. It was just before Thanksgiving 2005. He had a mild heart attack and was admitted to a hospital in Rochester, New York. And while recovering, he developed bacterial pneumonia, an infection he got while in the hospital. Thankfully, his doctor caught it early, treated him with the right antibiotics, and he fully recovered. But that was our warning shot, and it wouldn't be the last. So I like to fast forward now to the year 2000. My wife, Victoria, decided to do something for herself, mini mommy makeover, as they call it. She opted for saline breast implants. And at first, everything seemed fine. She felt good and she was confident, but slowly things began to change. She developed strange symptoms: deep fatigue, aching joints, rashes, and numbness in her arms and legs. Even her tongue would stick to her roof of her mouth from dryness. We went to every doctor you can think of: dermatologist, neurologist, rheumatologist, you name the ologist, we saw them. Eventually, a rheumatologist told us she had developed an autoimmune disease, very likely triggered by the implants. Even removing them would not undo the damage. And when she finally did have them removed, they discovered a biofilm of staph epi growing all over them. So breast implant illness, or BII, is actually real. It mimics autoimmune disease and in some cases becomes one. Victoria's symptoms continue to this day. She lives with them, manages them, and she's not alone. And then there's Josh, our son. Josh was 27, living his best life in Colorado. He was a skydiver, full of life, full of adventure. But on Labor Day of 2006, everything changed. He had a bad landing, shattered his femur, and fractured his skull. He was rushed to the ICU. 6 weeks he fought, not just to recover from the accident, but to survive two separate MRSA cases and then that he picked up in the hospital. He started to get better. They transferred him to rehab, and we began to hope. But then suddenly he spiked a fever, became violently ill, and fell into a coma. Doctors rushed to his spinal tap. His cerebral spinal fluid was full of deadly gram-negative bacteria, and they performed an emergency brain surgery to relieve his swelling. Josh survived that, but not without devastating consequences. Josh became a ventilator-dependent quadriplegic. He couldn't move, he couldn't breathe on his own, and yet, through it all, he was still Josh, still conscious, still fully aware. As he laid in the ICU for those final days, over 70 of his friends gathered in the hospital lobby. They stayed there 2 full days, just waiting to say goodbye. And they shared stories, funny, sweet, raw memories of Josh. I remember standing there at the foot of his bed, just outside his field of vision, listening as his friends say their goodbyes, watching these young people full of strength and life suddenly break down into tears as they whispered their last words to the friend they loved. When it was finally my turn, I turned. I didn't know what to say. What do you say to a child when the world is about to lose? So I leaned in close and whispered what I had said to him ever since he was born. I love you so much. Josh passed away shortly after that. He was 27, and every day since, my world has never been the same. Hospital-acquired infection, also called healthcare association infection or nosocomial infection, are not rare. They're not random, and they're not unavoidable. When I asked the infection preventionist at the hospital that Josh was at, how did he get this infection? He looked on and said, I just don't know. And that broke me, but it also opened my eyes. No one person can fight every germ, but the system can, if we choose to. So I started asking questions, reading papers, meeting with experts, and I realized something powerful. Patients, families have a vital perspective that's been missing from this conversation. In 2018, MedStar Health, one of the largest healthcare systems in the Mid-Atlantic, they approached me and they were launching a system-wide initiative to address sepsis. and they asked me to lead that effort. I was utterly surprised. I was just a grieving father, not a clinician. I remember thinking, got the wrong guy. I don't know anything about sepsis. But I showed up anyway. And what I brought, what any patient can bring, was a different kind of insight. I learned that 80% of sepsis starts outside the hospital, and that in the ER, people were waiting 3 to 4 hours before even being evaluated. As a layperson, that did not make any sense. So I asked, what if we screen for sepsis at the door? What if we integrate it into the electronic medical record? They said it may not be perfect. It might lead to some false positive. But if we saved even one life, wouldn't it be worth it? It was worth it, right? In the end, we reduced sepsis mortality rate by 35%. We passed legislation, won awards, published papers, but more importantly, we saved lives. And so I share all of this not for sympathy, but for action. Because every caregiver, every administrator, every policymaker, you have the power to make care safer through your choices, your attention, your voice. And if you made it this far into this episode, thank you so much. I hope Josh's story, my family's story, stays with you, not just as a cautionary tale, but as a call to action. Because when we get this right, when we truly commit to preventing infection, we don't just save patients. We save mothers, we save fathers, sons. More importantly, we save families. Thank you.
Wow, that's pretty powerful. Just looking back at his hospitalization or like your father's experience or even your wife's experience, is there just anything that was glaring to you that possibly could have been done different?
Yes, quite a bit. I mean, this is an interesting question because now we're talking um, time, right? I mean, how we used to give care back in the 1800s, not how we do care today in 2025. So in 2006, when Josh was hospitalized, the one thing that, and of course, I knew nothing about healthcare, but in looking back, I remember there was a coffee pot in a hallway in the ICU. That's a no-no. That's a first. Everybody touches that coffee pot. So you go into a room to a patient who's in ICU, and you come out to get a cup of coffee, and you just contaminated that coffee pot. Hand hygiene was not as compliant as it is today. We didn't have that knowledge that we have today, because today we even have technology that even talks to you if you don't wash your hands or sanitize your hands when you walk into a room. So the care that was given back then, I could turn around and say this and this and this, and there's a whole slew of things that they could have done differently. But the more importantly was hygiene. My wife, his mom, had to give him a bath because the hospital was not diligent enough. Josh's fingernails were black, just poor hygiene. So, if you don't keep the place clean, or you don't keep the patient clean and protect the patient by you washing your hands, sanitizing your hand, something bad is going to happen. It's inevitable. It's not if, it's when.
Yeah. Well, even right now, the CDC, another thing that we're looking at is the stethoscope that goes from patient to patient. In fact, the CDC is calling it the third hand because we're finding the same pathogens on your hands or on our stethoscopes.
Yeah. It's really ironic because my wife and I were asked to speak at one of the hospitals. It's HCA here has hospitals in London, England. And so they asked us to speak over there. And we found out that doctors over there no longer can wear a tie because the tie would just swing over and
That
be
makes sense.
contaminated.
Mhm.
Yeah, it's really crazy. So
That
things
completely
like,
makes sense, though. Yeah. Right.
yeah, I mean, they're just,
Yeah.
you lean over and that tie just picks up everything. So, yeah. But yeah, a lot has changed, but we have a long way to go.
I completely agree with you. So, one of the things I wanted to talk about was the organization you started after Josh's death. Can you talk a little bit about that?
Well, I don't know which one you're referring, because we started three different organizations. So the
Okay, tell
first one,
us.
well, the first one that we started is called SafeCare campaign, because living in Atlanta, my wife and I reached out after Josh died to the CDC. And we thought that's a great place to start. As a layperson, I thought that's a federal agency. That's the first place we should go. And they're right here in Atlanta. 45-minute meeting ended up being 3 hours. They were extremely generous with their time. And the entire epidemiology department met with us. And when I asked the question, you're a federal agency, you can't do anything about this? And they actually looked at me and they said, "No, we can't. We just put out guidelines." And I said, "Well, who can?" And they all pointed in my face and they said, "You can. Go out there and tell the story." And so they encouraged us to start something, and whether you call it a movement, a website, or something. So we started SafeCare campaign, which was really based on infection prevention. And then, of course, they asked me to be on their council of infection prevention. So I sit on their council and participate in a lot of the discussions on infection prevention. But that that only worked for a little while. So hospitals got they started calling us and, oh, we heard about your story, your family story. We'd like you to speak at our hospital. We'd like you to be a keynote speaker at APIC, infection prevention conference. It was great. But one year I was flying back from Washington, D.C., and I started thinking, you know what? How long does that message resonate? 3 months, 6 months, and then what? You're going back to do whatever you were doing before, right? And if somebody takes charge, if you have a nurse manager or somebody that takes charge of, let's say, a hand hygiene compliance program, she goes on vacation, then what happens? And sure enough, I found out that that number goes way down. So I started thinking, you know what? What's missing is the patient's voice. We need a partnership here. We need to get the patient involved in this. And at that time, CMS was launching the Partnership for Patients under the CMS Affordable Care Act, right? And so we go down in our home and develop tools to help hospital engage with patients and family. Therefore, patient and family advisory councils. And we added the QNS to make it for quality and safety because my thought was that although, yes, I do think the patient experience is important, but let's not just stick to that because patient experience should be the umbrella that encompasses quality and safety. If you go out in the street and you ask any person on the street what's important when you go in the hospital, it's not the color of the walls. It's not the kind of food that they provide you with. It's to go home safe and sound after a procedure and no readmission. That is the number one thing that people want. So building these PFACs became so successful, they became a model. And that's how I got connected with MedStar because we built all of their PFACs. And then BHA, which today is Vizient, they engaged us to do the same thing. And then after that, I thought, okay, you know what? That's my voice. Armando's work on infection prevention, building PFACs and all that. But what if we get 10 of us, known patient advocates, nationally known patient advocates, and we get together and together we'll have a stronger voice? Sure enough, we developed Patient for Patient Safety US or PFPS US, which is a chapter under the World Health Organization. You got to be careful today to say World Health Organization, but but um, but yeah, we move mountains because we get in the conference with CMS and they'll say things like, "Oh, guys, we like you to say X, Y, Z because you can say it, but we can't." So we have now passed the structural measures. We've published a ton of papers. It's just gave us a platform where now we can go up to the hill and actually talk to congressmen and senators about the problems that this country is facing in healthcare.
Yeah. So let's say, what would you like to see happen in the next 5 years to 10 years?
Well, first of all, the number one thing is to make sure that patient safety is not politicized. Patient safety has to be front and center. I don't care what administration we have. It doesn't really matter. Patient safety is, and we are totally nonpartisan. It doesn't matter. I don't care who you believe in, what party you in. It's sooner or later we all go into a hospital. And so patient safety to me has to be front and center. And then I would like to see things like transparency and reporting. There has to be a place, there has to be a bank where patients can report an adverse event. And right now, people say, yeah, there is. You can report it to Joint Commission. Really? Show me what it does after that. It goes nowhere. We've done it. It goes nowhere. Um, so there has to be transparency and there has to be accountability for all of that. You cannot, we keep talking about driving healthcare to zero harm, but how do you get to zero harm? So you have to have patient and family engagement. You have to have transparency, and you have to have, accountability and oversight. If you don't have those things, you're just not going to reach that. And I love it when people say, they tell me, I walk in the hospital and they say, oh, we started a hand hygiene program. And it's our goal is 80%. I go, really? 80%. So the other 20% will die?
Yeah, it should
Your
be
goal,
100%,
your
right?
goal
Yeah,
should always be 100%, right? Now,
absolutely.
are you going to reach
110%.
100%? Yeah. Are you going to reach 100? Most likely not. It's
Yeah.
extremely difficult, even though it's such a simple thing to do, but it's extremely difficult. And not because you want to cause harm, but because in the middle of the day, especially running like crazy in an ICU environment, you forget that single most important component in the delivery of care and hygiene. It's very simple that it's missed often. So those are the
Yeah.
things that I wish in the next 5 years. I'm hoping to have them in the next 3 years, but I'm not so sure.
Yeah. Yeah, no. Well, I think all your points are valid. And, one of the hospitals I worked in, I remember it was just such a culture for us that we would give each other feedback like, hey, I saw you walk out of that room and didn't see you gel. Like, I mean, and it was so funny. I remember one time I got yelled at because I had gelled coming out of one patient's room, was walking down the hall, and then went into another patient's room and I got yelled at. And I'm like, no, I swear. I was walking down the hall doing it. But that's what it takes. It's we've got to be just truly holding each other accountable. And then, also I think doing root cause analysis when we have patients who have hospital acquired infection. And it really, our goal should be zero.
Yeah.
Yeah.
Absolutely. There's one thing that I tell every CEO that I meet, is they'll say, well, if there's one thing you would like us to do, what would that be? I say, I would like you to hold a meeting with every single person um, that you employ. I don't care if they work in the basement to clean, the tools. I don't care if they just clean the rooms. Every single person that gets a paycheck from you should be in that meeting. They say, and then what? I said, and then tell them that they are entitled to speak up. If they see something, say something. You have the power to tell them that, because what happens is, and as well as I do, a lot of nurses, they are afraid to speak up because, repercussion here and there, they shouldn't be. They should,
Yeah.
in the military, if you see something, you say something. It's just common sense. And that's how you learn from your mistake. We filed a complaint with the Office of Inspector General when the Vanderbilt case happened, a couple of years ago. Why? Because granted, the nurse made a mistake. She killed the patient. Sure, but you have to support her. You have to step up to the plate. She worked in your hospital. You have to say, we made a mistake. It, it just, you can't do the hiding because you're not learning from any mistakes you make. So
Well, I just want to thank you for being here today. I want to thank you for all the work you've done and just really
thank you.
honoring Josh's life and, truly making a difference in healthcare. I just really appreciate all the work you've done.
Thank you so much for having me.
Are you a nurse, infection preventionist, or healthcare professional who wants to stay ahead of the curve? Visit sepsispodcast.org to learn how you can receive free nursing CE credits by listening to or watching the Sepsis Spectrum. It's our way of supporting you and together better understanding the ever-evolving world of sepsis care and AMR. And now, back to the show. So now I am joined by Dr. Hudson Garrett, who has done a lot of work in infectious disease and quality improvement. So welcome to the show.
Thank you so much for having me.
Yeah. So we heard an amazing interview and just so much work that's being done in a legislative way to try to make change. So now what I want to do is kind of drill down and talk about a lot of the work that you've done with antimicrobial resistance and antibiotic stewardship and quality improvement in those areas. So can you tell us a little bit about some of the work you've done?
Yeah, so I mean, I think intentionally, my background in infectious disease touches on a lot of different stakeholders. And when you think about antimicrobial stewardship and resistance, it's a true community issue. It's one that, frankly, we don't talk near enough about. The implications reach far beyond even sepsis. And so, when you think about a patient who, for example, doesn't take their full dose of antibiotics, they think, well, that's just a problem limited to me. And the reality is it's not. And so I've really enjoyed sort of bringing the different facets of medicine together, whether it's infectious disease or quality or patient safety, and even concepts like risk management to the table, so that we can sort of bring those intricacies to the same table and have the dialogue that's more interprofessional. Healthcare, whether it's sepsis or HAIs or surgical site infections, each of those is a complex issue. And it requires a lot of different disciplines to come together and sort of put egos aside and say, let's solve the problem. And our patients are desperately seeking that. And that's really where my fundamental focus is on breaking those silos, bringing those stakeholders together, and fundamentally trying to get to the root of the issue.
So can you give me an example of if you can think of a case or if you can kind of bring in a practical approach to how this is done in hospitals?
Well, I think there's a gap analysis that has to start to your question. You know, what's the current state versus the desired state? So many healthcare facilities, whether it's a hospital and frankly, even places like long term care, you know, the resources may be scarce. They may not be near as appropriate as they need to be. And so I always say start with where you are today and think about where you want to go in the future, because stewardship, resistance, understanding, patient education, and sort of in building confidence with our prescribers is a journey, and you can't just start and say let's break down all the doors immediately. And so I always say start there. The second thing I think about is getting stakeholder engagement, making sure that you have the right people sitting at the table that have the desired outcome in mind, that are saying yes, that sounds like a great place to go, I'd like to be a part of that initiative. And getting input from patients, I think, is absolutely critical. I mean, that basic concept of consumer feedback. I mean, at the end of the day, they're the ones that pay the paychecks, and they have to be at the center of the care. But there's also that dimension of the healthcare team's engagement. And I think sort of the fourth dimension of my mind is, are we actually moving the needle? And that's where the data, the performance improvement, and frankly, the quality component comes in of, are we going in the right direction? And if the answer is yes, then fantastic, let's keep going. The answer is no, let's figure out why we're not moving in that direction, and let's make some tweaks and some adjustments and continue to ideate.
So, in your experience, what have you found some of those tweaks and adjustments are? Because I think this can be a monster of an issue to try to tackle. So, what have you found that's been more practical that has helped?
I mean, probably fundamentally is leadership engagement. I mean, when you have a good culture and a good leadership engagement, and an executive leader, particularly, that's engaged, a lot of things are possible. Not just in the topic that we're discussing today, but just fundamentally, truly transforming care delivery, and not just doing it for today and even tomorrow, but the true future, building those truly transformative care systems that are highly reliable. I think that's probably number one. But two is really fundamentally getting to the root of the issues. If you think about stewardship, why do we have problems with stewardship? It's no different than basic concepts like hand hygiene. It boils down to organizational cultures and process management and accountability, and sometimes having difficult conversations, right? Antibiotics are one of our most important portfolios of medications that we have at our disposal, and we have got to protect them at all costs. The implications of antibiotic resistance is tremendous, and yet sometimes we just sort of become complacent from that perspective. And so it's really critical to also remind ourselves that complacency kills, and our patients have a high expectation of safe, reliable, and affordable care. And if we go back to those core tenets, I think we always end up at the right place. But losing sight of that sometimes can become easy, and it's a good reminder for us to step back and focus on the most intentional efforts.
Well, how do you take what you're talking about? Because you're talking about bringing people together, and from definitely from a leadership perspective. But I always wonder how often does that information make it to those that are doing the work at the bedside? And because I truly, those are the people you've got to engage. And so, what have you found that has worked? Because I find so many times I'm in these big meetings, and yet the people doing the work don't get the information. So, what have you found that's worked?
Interactive dashboards, I think, are certainly helpful. Pushing information to them in a format that works. Putting people to your point in a staff meeting or a once a month committee meetings, that's completely antiquated. Providing retrospective information is not helpful. If I tell you, you had this patient and they were here 15 days ago, you should look at me and say, well, that's completely useless. That patient's long gone. The length of stay is over. The patient is out of the facility. What do you want me to do with that other than just learn from it? But true real time information, whether that's laboratory diagnostic notifications or understanding the antibiogram and really looking at susceptibility and resistance profiles, and frankly, engaging patients in true, meaningful competency of really engaging in their treatment. We're great at printing off a lot of patient education plans. And we're terrible at getting good competency with our patients and their families to understand their condition. I think new onset diabetes is a great example of, well, here's your 40 pages of, information on your new diagnosis. Well, that's not good. That's not going to be effective for them. So here, whether it's sepsis or something else, we've got to give real-time information that allows for strategic evidence-based and data-driven decisions, to your point, to the frontline clinicians that are making those decisions. When we do that, we not only help the patient, but we also help create better engaged stakeholders because they feel like they're part of the solution and they feel like they're truly in a system that actually is working in the favor of the patient as well as the team that's delivering the care.
So, can we drill that down a little more? So, what does that look like practically? Like, what does that look like? Are there, um, do you have screens set up in, like, for example, workstations, or are reports delivered on the patient? Like, I just want to walk through, like, what does that look like to truly make a difference?
I mean, today you see dashboards. I think is really where we are today. In the future, though, I think that's going to completely transform. And when I say future, I'm not talking about 10, 15 years. I'm thinking 3 to 5 years, especially with these new AI technologies, we'll be able to truly individualize treatment plans. We're already seeing this with antibiotics, where we can make more individualized treatment, based on even the facility's antibiogram to really look at the microbe that we're trying to treat with the susceptibility and the resistance profile. Well, that's a great thing for the patient. And it's also great for us. We're not going to hit them with multiple antibiotics that are not going to work. We're not creating resistance profiles, but we need to take it a step deeper. If I'm looking at a patient that's in front of me, how do I arm that clinician with, preferably AI customized information that's pulling from the entire sort of plethora of databases that we have, the peer reviewed literature, as well as institutional data that says, based on, this patient, Nicole, sitting right in front of me, this is the best option. That's truly transformative. And it's also going to decrease costs, it's going to improve quality, and it's going to make our healthcare system so much more efficient from the patient's perspective, too, and hopefully decrease weight, which I think is really key for better outcomes.
Yeah, I mean, because the reality is that we just don't have enough specialists in hospitals to really deal with every patient who's got an infection, or, God forbid, a hospital acquired infection, and or even an antimicrobial resistant infection, to be able to one on one make decisions. I see AI being huge in this.
And I would say the laboratory space is far ahead of us.
Yeah.
We see laboratory methods that are much more sophisticated and advanced, which is fantastic. Even with the large national reference labs, they are doing some pretty stellar work in terms of real-time notifications, pushing that information to the provider, creating systems that allow us to make better decisions. And I think we need that in the drug space, and also in the medical device space too. We can't ever forget that sepsis is not just a drug related issue. It's not just a body system related issue, but devices can also be directly associated with this, like Foley's as an example. How do we automate some of those clinical workflows where our clinicians that might have placed a Foley 7 days ago are really thinking about clinical necessity of that line and really reviewing those types of things where it becomes second nature and we remove the human component that we know is not perfect out of the equation. And that's going to be the sweet spot that we've got to achieve.
Yeah, especially if we can make the information easy. I can't tell you how many times I've been at the bedside and I'm like, what Foley day is it anyway? And was this the original Foley? Our longer term patients, that information can be really difficult to dig out of a chart.
Absolutely. Absolutely. And the EHR had all the good intentions, right, to be created. And sadly, there's lots of data that goes into it, but we're terrible at pulling the data out and to the earlier point, making it provided in a meaningful way to our clinicians where it says, here's how you're performing, here's what you can do better, and here's how do we use that information to make better treatment decisions. Because our patient is expecting us to use every available data point to make a personalized decision. And that's what medicine has got to become is more personalized.
Yeah. And then I wanted to ask you about antibiotic stewardship. What do you find procalcitonin to be a helpful lab to follow? Or is there anything you see that's coming up on the horizon? Or what are your thoughts?
I mean, I do. I think it's part of our portfolio, right? I mean, it's almost like if you think about a CBC versus a lactate versus a this versus a that. When you have the total bundle collected, right, you get a much better holistic picture of that patient. One of the best examples I could think of that's correlated to this is collecting a blood culture. And we think about, well, we get some commensals back and we rush to go to try to treat it versus taking a step back and saying, well, let's look at the bigger picture. Is this a patient that's in the bed that actually looks clinically sick? Maybe a little epi is in the blood culture, but if the patient looks clinically well and they're completely hemodynamically stable, why are we treating this? And that's where I think we have to have more focus is, how do we combine good sort of, drug portfolios, better understanding of device related issues with this, good use of AI and some of the data, as well as some of these other components, and frankly, better systems. A lot of our systems in healthcare are just frankly not designed to talk well to each other, and they don't give us information that's a good output. I mean, I was looking at something last night, ironically, and there was something that was new in the system at the top, and I thought, what is that cool little button? And it said AI summary, and it said, would you like us to summarize the last 7 days for you? And so I just clicked it because my brain was excited, and it said, give us. I think it said, give me 10 seconds or something like that. And I thought, well, I'll give you 30 seconds. And 30 seconds later, it summarized all of the information in that medical platform. And I thought, oh my gosh, this just basically took something that would have taken me probably an entire day to go through 7 days of postings, and it generated it in a way that was completely personalized for me based on my profile. That's what we need to see more of. So that whether you're an ER physician or you're an infectious disease practitioner or you're a bedside nurse, everything should be customized also to you as the healthcare professional based on your expertise so that you can deliver your expertise to our patient. And I think that's going to make people really want to engage more on hot topics like sepsis, because sepsis is not going anywhere, sadly. It's going to always be a part of healthcare. But frankly, I want to make it sure where it's extinct. I want to, eliminate it as much as possible because that's what our patients deserve.
Yeah, absolutely. And I can say just from as a clinical nurse specialist, I've had to do M&Ms or patient case reviews, things like that. And it literally can take like 4+ hours just to do one case to gather the information to be able to click a button and get a summary. That would be amazing.
Well, and our colleagues in infection prevention and control have become heavily burdened on federal data requirements with the CDC, National Healthcare Safety Network. And that's become a problem, right? Because infection prevention and control is not performed behind a desk. It's not performed with data collection. And it goes back to what you said earlier. How do we truly transform care? Well, it's great to have data. It's great to have benchmarks. And don't disagree with that. But that's not helping the patient that's in the bed right now. Whether that's in the ER where we can intervene and stop sepsis before they have to go to the ICU, or whether that's a patient that's in the OR that starts to code where we can intervene as a rapid intervention. The more we get ahead of that eight ball with the different systems and technologies and better competency, I think that's where we're going to win. And it also engages our clinicians at a different level of granularity than where we are today.
Yeah. Okay, so we're gonna wrap up our interview. This has gone by really fast. Could talk to you all day. But let's say the year is 2035. What would you like to see from an infectious disease standpoint?
I think it's going to be something where we can individualize the risk profile of our patients to the point where it's almost like an ASA score when you come in for anesthesia, and anesthesia can sort of eyeball you and look at your anatomy and say, yeah, you're going to be a difficult intubation, and we're going to have this kind of trouble. We're going to need a glide scope, whatever it is. We need the same thing in terms of sepsis risk or risk for vessel preservation and some of the other core competencies associated with care of these critically ill patients. That I think is going to be actually pretty close. I don't even think we're talking about 10 years. The technology is moving so quickly. Our patients are certainly very interested. AI has so much capacity. And I think the FDA in particular here lately is very interested in registry data. So it's going to be quite fascinating to sort of combine all those different data points and say, wow, we can actually start to draw a lot of lines here and really collect this puzzle and actually draw some true conclusions about what's best practice, what's not, how do we adapt that, how do we become more agile, and then truly deliver personalized care to our patients, but also allow our clinicians to truly practice medicine and do so in a way that's not cookie cutter, not algorithm. The worst thing I think we ever did was create the BLS and ACLS algorithms because while they're great, they're also a double-edged sword where people say, well, it's not on the algorithm. What do I do? That's critical thinking. And so if we can utilize new technologies, whether it's laboratory or a medical device or drugs or AI, our clinicians are going to benefit from that. And at the end of the day, so are our patients.
Yeah, exciting. Well, I'm excited to see where the future takes us, but I just want to thank you for sharing your expertise and thank you for joining us on the show today.
My pleasure. Thanks so much for having me.
Wow, I am completely inspired by Armando Nahum and his story and really making something good out of something extremely tragic. And I'm so proud of Dr. Garrett Hudson for all the work he's doing with AMR and advocating and really getting involved with legislation and really trying to change the way we handle AMR and the way we deal with sepsis in the healthcare system. So I just want to thank you for joining me on today's episode of the Sepsis Spectrum. If you like the show, we want to hear about it. Please leave a review wherever you're enjoying this podcast. It helps a ton. You can also reach me and our awesome team at info@sepsis.org or visit sepsispodcast.org to share any stories of your own, questions, concern, or episode ideas. To learn more about Sepsis Alliance, visit sepsis.org. The Sepsis Spectrum is brought to you by Sepsis Alliance. I'm your host, Nicole Kupchik. Our executive producers are Allison Strickland, Hannah Sass, Claudia Orth, and Alex Colvin. Our producers are Aaron Corney, Rob Goldman, Shanti Brooke, and me, Nicole Kupchik. Our post-production producer is Tim Scott. Our editor and engineer is Jason Portizo, and our music is by Omer Benzvi. To learn about Sepsis Alliance's podcast legal disclaimer and compliance policies, you can visit sepsispodcast.org/disclaimers. The Sepsis Spectrum is a human content and Sepsis Alliance production. Thanks for watching. I hope you're enjoying the Sepsis Spectrum. Leave a comment below and let me know. If you want to binge some more episodes, just click that playlist right over there. And if you're feeling super generous today, give this video a like, subscribe if you haven't, hit the bell, all the things. And of course, you can also listen on the go wherever you get your podcasts. Bye.